Hi guys. I've got to warn you, one of the first things Alicia said to me when she picked me up at the airport yesterday was that I'm not much of a talker. And true as Bob, I'm not. So if you're wondering why an Afrikaans techie is standing in front of you doing public speaking, which is probably the thing I despise most, is because I think it's a message that matters, enough to kind of move way out of my comfort zone. So please ignore the packaging and see if you can focus on the message, because I think because I think it's a message that can truly change the world. Okay. Well, as I just said, I'm Malan. I'm going to be sharing with you some of the things I've seen and worked on in the mobile health space. I'm hoping that the talk will firstly inform you, but hopefully inspire you to join what is rapidly becoming a global revolution in healthcare. Should maybe change the slide. Hey, that's cool. Okay. That's actually my title. Alicia took another one. It's Curing Healthcare. Okay. As you guys are no doubt aware, healthcare globally sucks. It's a massive problem in poor countries and in rich countries. However, before I start in earnest, I'd like to test an hypothesis with you guys. I'd like to request that everyone who has access to private medical aid or something similar, please raise your hands. Cool. Thanks very much. And congratulations. Only 20% of South Africans can make that claim. So only 1/5 of our population are guaranteed to receive quality healthcare. The remaining 80% rely on the government to provide them with healthcare. Now the really scary thing is that we, the elite, consume 60% of all healthcare resources in South Africa. Just think about that for a moment. 80% of our population get less than half the resources. We take the rest. Now, this isn't merely an SA problem. It's a global problem. As a species, we tend to not take great care of our sick or frail. This is most evident among the poor, who seem to consistently get the raw end of the healthcare deal. It's somewhat ironic and sad that we've replaced discrimination by race with discrimination by economic standing. I think the only real difference, ironically, is that on an international forum, the latter is far more acceptable, and probably has much less a chance of being changed for that reason. I've chosen to do a comparison between the United States of America and South Africa in terms of healthcare. Now, the interesting thing is, as many of you might know, is that the United States is actually the only country, the only wealthy industrialized country that hasn't implemented universal healthcare. However, even taking that irony into account, it's scary how much more money the US spend on healthcare than South Africa. The United States government spends about $3,000 every year for every citizen on healthcare. Now, their private citizens contribute even more. South African government spends less than $350. Now, this discrepancy is evident in many other things. For every one laboratory health worker, a researcher we have, the United States has 20. That means they're engaging in long-term research while we lag behind. So, we have less money, less research than the United States. Now, the scary thing is we also have a hell of a lot more disease. If you take something like TB, which is quite an expensive disease to treat because it's chronic, for every case of TB in the US, we have 250. Okay, so we have a lot less money, less research, and I have a lot more disease to cover. So it's a big frigging problem. Okay. However, there are a few factors that do count in our favor. Due to a kind of set of seemingly fortunate and unfortunate circumstances, South Africa is actually a leader in the mobile space. Now, the United States has one of the best fixed-line telephone networks in the world, as many of you might know, that provide inexpensive service to all its citizens. Now, South Africa has really pathetic fixed-line service, as all of you would know. We have really bad penetration. I think it's sitting on like 11%. Service is horrible. Costs are exorbitant. We've got one of the most expensive costs in the world. Now, the interesting thing is that these factors might seem like really dodgy stuff, but what it actually has done is create an environment that's ripe for what the term is technological leapfrogging. And what's happened? South Africa's basically skipped the fixed line technology adoption completely and jumped straight into the mobile space. So, while the US is still clinging to a fixed line network, we have more mobile phones per person than most countries in the world, including the US, as you'll see over there. So that's really interesting. Because the really great thing about modern mobile phones is they can do a heck of a lot more than talk. You saw the older phone just now, which basically just talks. But everyone around here who's got a phone has got a hell of a lot more than just something that talks. Modern phones are really powerful processing devices with a wide range of embedded peripherals. Now, the power and flexibility of this platform can be used to solve a host of problems. And I think the most important among these will be found in the healthcare space. Okay. So getting back to South Africa, the acute needs we face cannot be solved trivially. I'm sure you'd all agree with that, otherwise they would have been solved. And I think it's important to say that they can also not be solved with the blind application of technology. The fact that we have more mobile phones and better coverage than most countries doesn't make anyone healthier, at least not directly. It's about the way we use it. Like any other technology, mobile phones are merely an amplifier of intent and efficiency. To address the problems we face, we need to change our thinking about the way we provide care and the way we use technology to provide this care. Now, one of the projects I've worked on and observed shows some of the ways in which a combination of paradigm shift and the correct application of technology can have massive effects. Cool. As I've indicated earlier, one of the core issues in South Africa is the amount of skilled experts we have and the resources to help those. So, South Africa has more than 40 million people on public healthcare out of the 48 million population. So we really have to do more with less. Now, we only have one doctor for every 1,200 patients, which is quite a shocking statistics. We also only have 4,000 primary healthcare facilities. That's not just hospitals, it includes clinics as well. And these 4,000 facilities have to treat the 40 million people on public healthcare. So it's no surprise that government healthcare isn't renowned for its quality. It's not because they're not trying. Now, the paradigm shift that is required or could solve many of these problems is a realization that many of the tasks consuming these 4,000 clinics currently could actually be performed outside of clinics by people who have less technical training than doctors, meaning that they're easier to train, easier to get hold of. Now, the South African government has embarked on a very ambitious project to move a large part of the primary care burden away from facilities. What they're doing is training what they term community health workers. These are people who work in their own community, providing basic, crucial health care to the people next to them. So a community caregiver looks after between 50 and 100 families, providing a wide range of critical services. So these would include social services, education, disability treatment, antenatal care, and treatment adherence if you're a chronic patient with HIV, AIDS, or TB. In short, they perform a number of crucial services that have historically occurred in primary healthcare facilities. So this drastically decreases the load on the facilities. Okay, now, let's see which slide this goes with. I have absolutely no idea. Okay, so sorry. If you can move a large part of this care burden out of the hospitals and into homes, you achieve two things. Firstly, it means that a lot of patients who would historically have had to travel great distances to get to hospital while they're sick, not in their own cars, but walking, public transport, stuff that's really great and that we don't know a lot about. So they can wait in their homes and someone actually gives them treatment there, which is actually a hell of a lot better than medic aid or whatever provides at the moment. The other thing is it allows hospitals to focus more on the few patients that remain, allowing them to provide a lot better care. So, currently there are more than 100,000 community health workers in the country. That's quite a large number. If you compare it to the 40 million, it seems like it could actually make a dent. And the government's planning on increasing this number to 150,000 in the medium term. So they've got a pretty good thing going. However, as with any paradigm shift, there are some initial obstacles. So, as soon as you start moving healthcare away from a central facility, you introduce a few problems. Firstly, tracking things becomes hell of a hard. it's hard to know where community health workers are, which patients they're visiting, the kind of care they're providing, and getting this data out of them is really, really difficult. Getting it back to hospitals is quite a challenge. So currently, community health workers are writing everything they do on paper and then trying to get it back to the hospitals. But as I've just said, they operate in the communities. These are often rural, far from hospitals. So there are a number of logistical constraints. It could often take weeks or even months for this data to get back to the hospital, not really a way to enable quick decisions and high visibility. So, also, most of the data is highly confidential patient information. Now, if it's in a physical building, it's quite easy to keep track of the paper. However, if it's people moving around, it's a hell of a lot harder to ensure confidentiality. So it's a really tough nut to crack, and the current paper-based solution just doesn't cut it. Okay. Now, Khayelitsha is one of the largest townships in South Africa. It's situated in the Cape Flats, and it houses more than 2 million people. I live in Stellenbosch, so it's right on my doorstep, so it makes sense to me. Now, there are a number of NGOs operating in Khayelitsha providing a whole host of services. One of these that's doing a really good job is Zanampilo. They're providing health services via community health workers. And they've got a number of links with high-tech companies in Technopark, which is where my security startup's actually located. So, the Nompilo project, meaning Mother of Health in Zulu, was started in Stellenbosch by a company called Geomed, very close to where I work at my startup, which has nothing to do with healthcare. It's a mobile solution to facilitate the work community health workers do currently and make it easier and more secure. So I got roped into this via my contacts at Geomed, and I designed and developed the mobile application and systems integration for Geomed with the help of 2 friends. So the Nompilo project team worked with Zanampilo to test the solution and get live data out in Khayelitsha, which has been really exciting. Now the solution we've developed makes use of modern smartphones with internet connectivity, digital camera, and GPS receivers. And it uses all of these to automate or completely eradicate many of the tasks health workers are currently performing manually. So when a health worker visits a patient, firstly, we issue patients with a 2T barcode that looks like that. That's phone readable. It contains a whole lot of medical information about the patients. So when a health worker visits the patient, they scan this code and immediately gain access to all the patient information without having to ask questions. The application then takes this information and, based on it, takes the health worker through a number of steps where they can input details on treatment plans, treatment adherence, and even schedule hospital visits right in the application. So all of this data is entered, along with the location of the visit, medical data, and patient information, and the duration, and all of that's encrypted and immediately sent to the hospital, connected with the community health worker, in this case, Zanampilo. So, suddenly, all of this data is available in real time at the hospital securely without any need to move around. Now, the pilot's currently running and providing live data. So what this is, it's a specific image of a visit that happened early in the month. The health worker visited right there. We've got it to about 3-meter accuracy or so. She spent 7 minutes and 20 seconds at the patient, scanning the code and asking a few basic questions. So in 7 minutes, 20 seconds, she performed the visit, got information, and it was beamed straight back at the hospital, which is a massive improvement from the weeks a month kind of stuff. So the data is immediately available for decision-making and scheduling hospital visits or whatever. Okay, this is a photo of during the training when we were training the community health workers to use the application. Okay, so it seems that the Nompilo project could be a great success. In the South African context, it solves many of the fundamental problems we face. So by leveraging South Africa's mobile phone technology and penetration, we can provide health workers with simple tools, hiding the technology, that can allow them to provide much better care. Now, this project's merely the start of something massive. Many companies, NGOs, and individuals are working in this field daily, creating really great solutions to combat the problems we face. So this paradigm shift has the potential to revolutionize healthcare globally and ensure that all of us live longer, healthier, and happier lives. And I invite you all to join it and read up on it, because you will be seeing it in the news much, much more frequently as time goes on. Thanks a lot.